Okay, finally we're to the unit where you probably all were imagining we would be when we were talking about psychology, which is abnormal behavior. People are really fascinated by the exceptional, the unusual, the abnormal. Why such a fascination with disturbed people? Even when we are well, do we see in them something of ourselves? At various moments, all of us feel, think, or act the way that disturbed people do so much of the time. We too get anxious and depressed, withdrawn, suspicious, deluded, just less intensely and more briefly. No wonder studying psychological disorders sometimes evokes an eerie sense of self-recognition, one that illuminates our own personality. To study the abnormal is the best way of understanding the normal, says William James, who you should remember. So we're going to look at Intro to Psychological Disorders. This is Module 65. And here are some of the questions that we are going to answer. So first of all, the World Health Organization reports that worldwide about 450 million people suffer from mental and behavioral disorders. It accounts for about 15.4% of the years of life. These disorders account for about 15% of the years of life lost due to death or disability, and it's completely under-diagnosed and under-reported for lots of different reasons. So what we're going to be exploring is how do we define psychological disorders in the first place? How do we get a definition? How do we know? How should we understand them? So how do the underlying biological factors contribute to the disorder? How do environments influence them and our own well-being? And how do these effects of nature and nurture kind of interact? And then, of course, how do we best understand and treat people with particular disorders? And then how do we classify psychological disorders? And can we do so in a way that keeps us from labeling people, which can be a dangerous thing? So a psychological disorder is a syndrome marked by a clinically significant disturbance in an individual's cognition, emotion regulation, or their behavior. Disturbed or dysfunctional behaviors are maladaptive. Maladaptive means that they interfere with your normal kind of day-to-day life, your ability to just kind of move about your day in a regular way. An intense fear of spiders may be abnormal, but if it doesn't interfere with your day-to-day life, it's not really a disorder. A cleaning ritual interferes with somebody's work and leisure. That becomes a disorder. It could be something like obsessive-compulsive disorder. If occasional sad moods persist and become disabling, they might signal a psychological disorder. So there you are. Over time, definitions of what makes for significant disturbance has definitely changed. Let me give you just a quick example that might bother some people. All the way from 1952 to December 9th of 1973, homosexuality was actually classified as a mental illness. By December 10th of 1973, it was not. It was taken out of the statistical manual, which you'll see in just a little bit. The American Psychiatric Association dropped it as a disorder because more and more of its members no longer viewed that as a psychological problem. Later research revealed, of course, that the stigma and stresses that often accompany coming out and being in a community that's accepting, that it did give people an increased risk for mental health problems, but it wasn't so much the homosexuality as it was the society's response to them. Right now, we're facing new kind of criticisms around attention deficit and hyperactivity disorder. So in this century, controversy is swirling over how frequent we are diagnosing children with ADHD. There's lots of questions about that. Thank goodness we live in a time where there is a medical model, because in the past, patients suffering from mental illness were treated in all sorts of disturbing ways. So in opposition to brutal treatments, reformers, including a guy named Philippe Pinel, who was French, he insisted that madness is not demon possession, but a sickness of the mind caused by severe stresses and inhumane conditions. For Pinel and others, moral treatment should be used, and included things like boosting patients' morale by unchaining them and talking to them, replacing brutality with gentleness and isolation with activity, filth with clean air and sunshine. While such measures did not often cure patients, they were certainly more humane and made a difference. By the 1800s, the discovery that syphilis infects the brain and distorts the mind drove even more reform. Hospitals started to replace asylums, and the medical world began searching for physical causes and treatments of different mental disorders. Today, the medical model is recognizable in the terminology of the mental health movement. A mental illness, also called psychopathology, needs to be diagnosed on the basis of symptoms and treated through therapy, which may include time in a psychiatric hospital. This image down here is of, under Philippe Pinel's influence, hospitals started to open up like socialization for its patients, and this is called they held actually something called lunatic balls. At the time, they were dances that were held in the mental facilities to try to increase like the social, people's ability to socialize and hopefully help them. Just a quick reminder that in the past, they even used cranial surgery trying to kind of release these spirits. I think phrenology and some of these other things, you guys saw a presentation on this earlier. The biopsychosocial approach. So today's psychologists contend that all behavior, whether called normal or disordered, arises from the interaction of nature, genetic and physiological factors, and nurture, which is your past and present experiences. To presume that a person is mentally ill, they say, attributes the condition to a sickness that must be identified and cured. But difficulty in the person's environment, the person's current interpretation of events, or the person's bad habits and poor social skills might also be a factor. Evidence of such effects comes from links between sporadic disorders, or specific disorders, and cultures. So cultures differ in their sources of stress, and they produce different ways of coping. Eating disorders like anorexia nervosa and bulimia nervosa, for example, have occurred mostly in Western cultures. In Malaysia, amok describes a sudden outburst of violent behavior, thus the phrase run amok. In Latin America, lays claim to susto, which is a condition marked by severe anxiety and restlessness and fear of black magic. And tajin hyofusho is social anxiety about one's appearance combined with a readiness to blush and a fear of eye contact, which appears in Japan. As does the extreme withdrawal of hikikomori. Such disorders have share an underlying dynamic, such as anxiety, while differing in the symptoms depending upon the culture. So in psychiatry and psychology, diagnostic classification aims not only to describe a disorder, but also to predict its future course, imply appropriate treatment, stimulate research into causes, and all kinds of other things. So indeed, to study a disorder, we first have to name it and describe it. And in psychology, the most common system for describing disorders and estimating how often they occur is to use something called the American Psychiatric Association's Diagnostic and Statistical Manual for Mental Disorders, shortened to the DSM. It's now in its 5th edition, and physicians and mental health workers use the detailed diagnostic criteria and codes in the DSM-5 presently to guide medical diagnoses and define who is eligible for treatments, including medication. For example, a person may be diagnosed with and treated for an insomnia disorder if he or she meets all of the following criteria. For example, I'll show you in just a second. Oh, wait, that's not it. Dissatisfied with sleep, Sleep disturbance causes distress and impairment, occurs at least 3 nights per week, is present for at least 3 months, occurs despite adequate opportunities for sleep, and isn't explained by some other disorder. So if you could say yes to all of those things, that's what the DSM would use in part to help guide through a diagnosis of insomnia disorder. In this new DSM edition, some diagnostic labels have been changed. For example, autism and Asperger's syndrome are no longer included. They've been combined into autism spectrum disorder. Mental retardation isn't the word used in the DSM any longer, and now it's become intellectual disability. New categories include hoarding disorder and binge eating disorder. There are criticisms of the DSM. Critics have long faulted the statistical manual for casting too wide a net and bringing almost any kind of behavior within the compass of psychiatry. They worry that the DSM-5 will extend the pathologizing of everyday life, for example, by turning bereavement grief into depression and boyish rambunctiousness into ADHD. Others respond that depression and hyperactivity, though needing careful definition, are genuine disorders, even, for example, those triggered by major life stress, as like a death in the family. So, anyway, there are just criticisms about it being too broad. So here's an example. For insomnia disorder, here are the bulleted list that the DSM would move through in order to ask somebody the types of questions that might lead to a diagnosis. One of the things that I would say would be a critique also that isn't mentioned in your text is just that this is all self-reporting, and we've looked at before at how dangerous kind of self-reporting can be, because our own perspective on what's happening with us might be different than the way an objective observer might view what's happening. Labeling psychological disorders can also be problematic for the following reasons. The DSM has critics who register a more fundamental complaint that labels are at best arbitrary and at worst value judgments masquerading as science. Once we label a person, we view that person differently, and labels create preconceptions that guide our perceptions and our interpretations of other people's behavior. So in a now classic study of the biasing power of labels, a guy named David Rosenhan and 7 others went to a hospital admissions office complaining of hearing voices, saying empty, hollow, and thud. Apart from this complaint and giving false names and occupations, they answered the questions truthfully. All 8 normal people were misdiagnosed with disorders. So should we be surprised? As one psychiatrist noted, if someone swallows blood, goes to an emergency room, and spits it up, should we fault the doctor for diagnosing the person with a bleeding ulcer? No. But what followed the diagnosis in the Rosenhan study was startling. Until being released an average of 19 days later, the patients exhibited no further symptoms, such as hearing voices. Yet after analyzing their quite normal life histories, clinicians were able to discover the causes of their disorder, such as reacting with mixed emotions about a parent, a routine behavior of taking notes was misinterpreted as a symptom of something else. So at the end of the day, they just feel like labels matter. When people in another experiment watched videotaped interviews, those told the interviewees were job applicants perceived them as normal. Those who thought they were watching psychiatric or cancer patients perceived them as different from most people. Therapists who thought an interviewee was a psychiatric patient perceived him as frightened of his own aggressive impulses, a passive dependent type, and so forth. A label can, Rosenhan discovered, have a life and an influence of its own over somebody else. Surveys in Europe and North America have demonstrating the stigmatizing power of labels. Getting a job, finding a place to rent can be a challenge for those known to be just released from mental hospitals. But as we are coming to understand, the many psychological disorders are diseases of the brain, not failures of character, the stigma seems to be starting to lift. There are all kinds of stereotypes in our media as well. As Good as It Gets, Silence of the Lambs, Black Swan, all sorts of movies portray mental insanity in a negative light. In the last couple of seconds, I'm just going to show you a couple slides of diagnostic percentages. You can pause if you'd like.